Hello Hematology 1 students! In this next set of videos, we will be tackling acquired hemolytic anemia. So in this first part, we will be talking about acquired non-immune anemia of increased destruction. And this is found in page 117 of your module. But before that, let me share with you this wallpaper. Okay, so some of you are probably thinking, HEMA again, exam again, and your second unit exam score is still weighing down on you. But it says here, don't let self-doubt deter you from progression. Always focus on learning. Second unit exam has already gone past you. There's only third and the fourth and the finals before you. If you let the second unit exam drag you back, then you will never get forward. So find that hope within you. Make it spark, make it burn. So that when you start reading, then you do so with a lighter heart and you're able to focus. Okay, so let's start with this. I suggest that you pay attention so that you could get as much notes as you can, and you don't have to listen to this presentation twice. Okay, so let's jump into this. We have acquired non-immune anemia of increased destruction. Acquired hemolytic anemias are divided into two, non-immune and immune. Whenever we say non-immune, there are no antibodies involved. The RBCs, the erythrocytes, would have a shorter lifespan because of physical or mechanical injury, while in immune anemia, the red blood cells are being destroyed by antibodies, therefore the term immune. So under acquired non-immune anemia of increased destruction, it's further divided into two general portions. We have acquired extracorpuscular defect or extrinsic defect, and acquired intracorpuscular or intrinsic defect. Of course, when we say acquired extracorpuscular or extrinsic defect, that means that there is something wrong with the blood vessels or with the environment where the RBCs are. And under this, we have microangiopathic hemolytic anemia, of which there would be 4 examples. We have macroangiopathic hemolytic anemia, and those are the 2 major ones. Okay, microangiopathic means that the abnormality would be in the small blood vessels, while macroangiopathic would be in the larger blood vessels. And then for acquired intracorpuscular defect or intrinsic defect, we only have 1 example, and that would be paroxysmal nocturnal hemoglobinuria. Finally, it's here. And you've been hearing about it since, I don't know when, probably in your clinical microscopy 1 for those of you who have taken it, or since in hematology 1, it was first mentioned, I think, in aplastic anemia. So we'll start with acquired extrinsic defect. Microangiopathic hemolytic anemia, or MAHA, is also known as thrombotic angiopathies. And this is a complication leading to disturbance of the microvascular environment or the small blood vessels. This could be potentially life-threatening, and therefore it is a group of disorders that should be looked into and should be diagnosed early for proper treatment to commence. The most common causes of MAHA would be fibrin deposition, and that's what you see here in this picture. If you can see the strands right here, okay, those are fibrin strands that should not be found in your blood vessels or in the patient's blood vessels. The problem is when these strands trap red blood cells, like this one's over here, so these are the trapped RBCs, then the trapped RBCs, since it's in a fast-flowing environment, would get ruptured. Okay? Or sometimes the fibrin strands are even blocking the blood vessels to some degree, and that causes the RBCs to lyse. It could also be due to severe systemic hypertension, so increased blood pressure, and the red blood cells are destroyed because of that increased blood pressure. It's just like being in a whirlpool or a washing machine, let's say. Okay, and we have other vessel abnormalities that could be due to activation of coagulation system or the platelets. The problem here in microangiopathic hemolytic anemia is that the red cells will be lysed or destroyed. It will start to reseal itself, so it has a self-healing capacity, but it would have a different shape. Therefore, we have schistocytes as a characteristic finding in microangiopathic hemolytic anemia. And the severity of the anemia would depend on the bone marrow's ability to compensate for the anemia. Well, hemolysis here could take place within the blood vessels or out of the blood vessels, mostly within the blood vessels. And just like any other hemolytic anemia, there would be, the patient would have an RPI of greater than 3, and the morphology of red cells would be normocytic, normochromic. However, since most of the time there is abnormal clot formation, then there would also be decreased platelets, okay, or activation. There would be abnormal activation of platelets. Therefore, the platelet count is reduced or low. So we have schistocytes and thrombocytopenia as the characteristic features of microangiopathic hemolytic anemia. I'm supposed to show you a video right here, but I guess it's not playing, so maybe I could just share it with you in class if we have time. Okay, so as was mentioned a while ago, for the laboratory findings, we have schistocytes and thrombocytopenia. Okay, let's go to the first example of microangiopathic hemolytic anemia, which is disseminated intravascular coagulation. For DIC, there is no age preference, and DIC is a generalized activation of hemostasis in response to a systemic disease involving all the hemostatic mechanisms. So there would be a trigger, and the coagulation system of the body is activated. From the name, we have disseminated, so it's scattered. Intravascular coagulation, so there would be formation of blood clots in different parts of the body. So it's all throughout, and it's mainly in the small blood vessels. And you could just imagine if there would be clots, right? Like here, if there would be blockage. It will not only trap blood cells, but it would also block the blood vessel and the blood supply to whichever organ that blood vessel is supplying. So the common triggers could include bacterial toxins and insect bites, okay? And because of this, it would trigger the coagulation system. There are two types of DIC. We have acute and we have chronic. But DIC is also discussed in hematology too, because it's there's a problem with hemostasis, and hematology too is hemostasis. So most of those mechanisms will be discussed in hematology too. Okay, so again, there's no age preference. Old and young can have DIC. So what are the laboratory findings in DIC? There would be coagulation abnormalities since the coagulation proteins are used up. This type of clotting is not needed by the body. Remember, clotting only should take place when there is injury, tissue injury, or blood vessel injury. But in here, there is no blood vessel injury. So the coagulation system is activated, and therefore the coagulation factors or the coagulation proteins would be used in this process. And that would lead to a low amount of the coagulation factors. And if we test for those using prothrombin time and activated partial thromboplastin time, then it would give you a prolonged result. So PT and APTT would be the screening tests used for hemostasis. We have here several other tests like thrombin time. Thrombin time is to determine the activity of fibrinogen, whether there's enough fibrinogen that could be converted to fibrin, which is a final base, or it's what holds the clot together. Okay. Fibrinogen levels, of course, are also decreased because, again, it's used up, it's converted to fibrin, and therefore if you measure fibrinogen, there would be lower levels. And we have increased levels of fibrin degradation products. Remember, in hemostasis, we have primary hemostasis, secondary, and tertiary. Tertiary hemostasis is when the clot is finally destroyed so that everything would go back to normal. And since there is clot formation, there is constant fibrinolysis right here, and the products of fibrinolysis would be elevated. Okay, so we have coagulation abnormalities, meaning coagulation tests are not normal. The platelet count is decreased, so we have still thrombocytopenia, and schistocytes are present on the peripheral blood smear. And just like before, the morphologic classification is still normocytic, normochromic. Since the hemolysis is within the blood vessels, there would also be increased serum LDH and decreased levels of haptoglobin. What's the difference between acute DIC and chronic DIC? Of course, for acute DIC, it takes place within a short span of time, and more red blood cells are dying, and there is extreme hemolysis taking place. While in chronic, this takes place over a prolonged period of time, therefore it could sometimes be overlooked until it becomes worse. So more of the differences next semester. Here is a picture of a blood smear from a patient with DIC. And you would probably see the schistocytes right here. Okay, so these are the fragmented red blood cells. Okay, it's fragmented due to its passage through those fibrin strands, and sometimes they get trapped and all of those. Okay, I think this is a better picture. More schistocytes. So we have prolonged PT-PTT, decreased platelet count, and schistocytes present. Well, in your module, you might have there the granulocytopenia, thrombocytopenia, and all those. Granulocytopenia and toxic granulation. This is not really very specific for DIC. Toxic granulation would be inclusions found in white blood cells, and it usually denotes infection. So if the DIC was triggered by a bacterial sepsis or bacterial toxins, then toxic granulation could be present. Next, we have thrombotic thrombocytopenic purpura, the second of the microangiopathic hemolytic anemia. This is also known as Moscovitz syndrome and often seen in young adults, about third to fourth decade of life, depending on which book you would read. Okay, there is higher incidence in females. Okay, and this is caused primarily by deficiency of ADAMTS13, which stands for a disintegrin and metalloproteinase with H thrombospondin type 1 motif member 13. Okay, so ADAMTS13 deficiency causes TTP. And what's the job of your ADAMTS13? We have, it's supposed to cut the von Willebrand factor into smaller pieces. Okay, so von Willebrand factor is needed, remember, in platelet adhesion. Okay, and what it does is to allow the platelets to stick to the blood vessel wall. So this endothelial cell right here is part of the blood vessel wall. It's part of the tunica intima, and it produces ultra long von Willebrand factor multimers. So when it produces the Weibel palade bodies within the endothelial cells, when it releases the von Willebrand factor, it's in long strands. Okay, so it's ultra long. And what the ADAMTS13 would do is to cut it into pieces so that it would not lead to thrombosis. Because remember, the platelets would stick to the von Willebrand factor. It's supposed to unroll and stick to the endothelial surface, and then the platelets are supposed to stick to the von Willebrand factor through glycoprotein 1b, 9, and 5, remember? So ADAMTS13 is supposed to do that. But without this, what will happen? There will be too much of the ultra-long von Willebrand factor multimers. And in this next picture, you would see the effect of the loss of ADAMTS13 ADAMTS13. The von Willebrand factor will start trapping platelets, causing the formation of thrombi, or platelet thrombi, thrombus, if there's only one. Okay. Therefore, if you would look at the name, thrombotic thrombocytopenic purpura. Thrombotic because there would be a formation of the thrombus composed of platelets and the von Willebrand factor. Since the platelets are trapped with the von Willebrand factor, then the number of platelets in circulation that could help in stopping the bleeding would be low. So we have thrombocytopenia. Purpura is when blood would leak to the tissues. It's like hematoma, but it's not swollen. Small patches of, it's like a bruise. Okay, and that's purpura. And the reason for that is because the platelets are not available to seal the capillaries. Remember, that's one of the major functions of, or that's the regular function of platelets. It's to keep the blood vessel wall intact so that the blood will not seep out or go out of the blood vessels. But since there's low platelets, then the patient is more prone to bruises. So TTP, ADAMTS13 deficiency. ADAMTS13 deficiency could be either idiopathic or secondary, idiopathic or primary. So in idiopathic, they say that there could be antibodies to ADAMTS13. But at this point, they say possibly antibodies to ADAMTS13 deficiency. For secondary, we have infections, pregnancy. Infections, by the way, would be the most common cause of ADAMTS13 deficiency. We have pregnancy is the second most common factor. surgery, you have trauma, inflammation, and disseminated malignancy. It could also be inherited. Inherited is a mutation in the ADAMTS13 gene, and if it's inherited, it's called Upshaw-Schulman syndrome. Okay, so it could be either idiopathic, mostly associated with antibody formation against ADAMTS13 molecule. We have secondary, wherein it's caused by acquired factors, infection, pregnancy, and so on, and inherited due to mutation in the gene producing ADAMTS13. This is potentially life-threatening. Without treatment, TTP has a mortality rate of 90%. So 9 out of 10 individuals who do not get treated for TTP would die due to multi-organ failure. Clinical findings would include fever, fluctuating neurologic signs, and progressive renal disease. The neurologic signs and the renal disease would be due to blockage in the small blood vessels of the brain and the kidneys. The ones in red are characteristic findings. We have fever, and if you have your module with you, then it's the one boxed on the right side of page 118. So you have fever, neurologic signs, progressive renal disease due to vascular occlusions. For laboratory findings, the hemoglobin level is usually less than 10 grams per deciliter. In some books, it says 8 to 10 grams per deciliter. Of course, there's reticulocytes because the bone marrow is still trying to compensate for the anemia. And we have RBC fragmentation. Remember, this is still under MAHA, so we have schistocytes and thrombocytopenia, characteristic findings, the ones in red. We also have coagulation tests that are normal. That means the coagulation factors are not being used up as opposed to DIC. So now we have one test to differentiate DIC from TTP, and that would be coagulation tests, yes, particularly PT and APTT. The PT, or prothrombin time, and activated partial thromboplastin time for TTP is normal, as well as the thrombin time. Okay, thrombin time is normal, fibrinogen levels would be normal, FDP or fibrin degradation products would be negative. Okay, and since this would be due to intravascular hemolysis, there's markedly elevated serum lactate dehydrogenase activity, as well as reduced or low haptoglobin levels. Okay, so remember, if there's hemolysis, the haptoglobin will attach to hemoglobin and therefore it cannot be measured. Here are pictures of blood smears from patients with TTP. If you would notice, you have the schistocytes, and right here in this other picture, this is your nucleated RBC. So it could get the patient could get really anemic, and the bone marrow will start releasing young red blood cells because it can do so. Next, we have hemolytic uremic syndrome, HUS, and you've probably heard this first in bacteriology for those of you who have taken it. This affects infants and children, although pregnant women would be one group that would have a high incidence of hemolytic uremic syndrome. So hemolytic, there's hemolysis, hemolytic anemia. Uremic, that means the kidneys are involved. Well, syndrome, a group of signs and symptoms that would lead to the diagnosis. The kidney problem here is much worse than that of TTP. Okay, so there are two types. This is not in your module, unfortunately. Just added it. So we have the D positive HUS. This has nothing to do with RH, blood group system, okay? and we have a typical HUS. Why is it D positive? Because it's preceded by an acute gastroenteritis and often with bloody diarrhea. So the D positive there is the bloody diarrhea. And the most common cause associated with this is infection with, yes, you got it if you remembered, E. coli na lang. Okay, E. coli 157H7. So this is the most common cause of acute renal failure in children. This because this E. coli right here is able to release the Shiga toxin that destroys or disrupts the endothelial cells, causing formation of the thrombi locally, and that would be in the blood vessels of the kidneys, causing acute renal failure. So most of the time, D positive HUS is found in young children. Supportive therapy is provided for patients, and it resolves spontaneously, so there's not much of a problem. How about a typical HUS? So only about 10% of the cases would be atypical. So atypical, not usual, right? D positive HUS would make up about 90% of the total HUS. In atypical HUS, there is no diarrhea, okay? So it's not preceded by bloody diarrhea and more commonly found in adults. So it could either be familial or sporadic. Usually if it's found in adults, it has a poorer prognosis, and this could come back, like the patient could get well and then get HUS again, and then get well and get HUS again. What's the difference between familial and sporadic? Familial is caused by mutations in the genes that code for proteins involved in the complement, particularly alternative complement pathway. So if the complement, remember complement would lead to cell lysis. If the endothelial cells are lysed, then it's injured, it could lead to activation of platelets and coagulation. Okay, so familial is caused by mutations in the genes that code for the proteins found in the alternative complement pathway. And that means familial or primary, and then we have sporadic. Sporadic would mean that it's secondary, or it's due to the exposure to certain drugs, having cancer, organ transplantation, pregnancy, and HIV infection. In some books, they even include immunosuppressive drugs and the use of oral contraceptives. There's also an infection that is associated with secondary atypical HUS or sporadic atypical HUS, and that would be Streptococcus pneumoniae infection. Okay, so it could also be triggered by infection. And according to Mackenzie, those atypical HUS secondary to diseases, okay, would have a higher risk of recurrence and a lower survival rate. Okay, so poorer prognosis for those that are triggered by infection for atypical HUS. Okay, so D positive HUS would have a better prognosis than atypical HUS. What are the clinical findings? We have vomiting, diarrhea, and abdominal pain, oliguria, decreased urine, or anuria, no urination at all. Wow, that must be hard. With dark colored urine, neurologic symptoms are present, but it's mild, not as much as the one for TTP. And we still have purpura and ecchymosis, or purpuric and ecchymotic lesions. These are bruises. Okay. And Thus, because of the thrombocytopenia. Just like in TTP, the hemoglobin is low, but it's lower here, 4 grams per deciliter as opposed to about 10, less than 10 for TTP. Thrombocytopenia is still present. Schistocytes are still present since this is still MAHA. But this time, since we have the renal problem, then burst cells are a common finding. So this time, the coagulation tests, PT and APTT, are still normal. Both are still normal, just like in TTP. So what then can we use to differentiate HUS from TTP? Okay. Because this would also lead to intravascular hemolysis. The most, let's see here. Maybe that would be the tests for kidneys. Okay, urinalysis would show proteinuria, hematuria, hyaline casts, even granular and RBC casts. And since there would be a renal problem, the BUN and creatinine are elevated or increased. So this would be a blood picture of a patient with hemolytic uremic syndrome. It's still normocytic, normochromic, guys, but nothing's changed. We have here schistocytes. You can hardly see the burst cells, although it's a little bit hard for burst cells because it's also one of the most common artifacts in the blood smear. Okay. Of course, there's still reticulocytosis, and the RPI is greater than 3. Here we have a table to differentiate the 3. Okay, so for HES, it's mostly in children, but it could also occur in adults, particularly that typical form. In TTP, it's commonly found in adults, 3rd to 4th decade, as well as, and more common in women than in men. In DIC, there's no age preference, but we have here adults, so it could still occur in children. All would have anemia. Oh, wow. Why is there no thrombocytopenia right here in HUS? There should be, so please add that. So in HUS, TTP, and DIC, there's thrombocytopenia and anemia. Okay. We have a peripheral smear showing MAHA. There's schistocytes, and there's an asterisk here because of the presence of burst cells aside from schistocytes. Okay. But all of this would be small blood vessels, this particularly small blood vessels of the kidneys. Here we have kidneys and the brain, and then small blood vessels all throughout the body. Clinical manifestation, predominantly renal for HAS, predominantly for the CNS in TTP, and DIC, it would depend on what triggered it. Okay. And TTP would have the worst prognosis. As was mentioned, 90% of those who are not treated die. Okay. Now let me add one more under MAHA. This is not in your module, so take down notes. We have HELLP, which stands for hemolysis, elevated liver enzymes, and low platelets. This is a condition, or it's a serious complication in pregnancy, particularly for women who experience preeclampsia or eclampsia. It occurs, it's a good thing that it occurs only in fewer than 1% of all pregnancies, but 10 to 20% of patients with preeclampsia would start to develop HELLP, unfortunately, in the 3rd trimester. Or maybe it's fortunate because they could just, if there's any problem, the baby would just pop out. 3rd trimester of pregnancy. So hemolysis, there would be destruction or fragmentation of the red blood cells in the circulation. Okay. There should be schistocytes, burst cells, elevated serum bilirubin, low serum haptoglobin, and significant drop in hemoglobin levels unrelated to blood loss. Okay, so any two of this would be enough to indicate that there is hemolysis, but most of the time there would be more than two. There would be elevated liver enzymes. Okay. We have increased AST, aspartate aminotransferase, or even alanine ALT, alanine aminotransferase, at least twice the upper level of normal. LDH, or LD activity, is at least twice the upper level of normal, so it's elevated. So LD, AST, or ALT would be elevated or increased. And just like in any other MAHA, the platelet count is low. So we have low platelets right here. The PT and APTT, if you're wondering, coagulation tests are normal for patients with HELLP. The platelet count usually is less than 100,000 per cubic millimeter, or 100,000 times 100 times 10 to the 9th per liter. If you cannot remember the normal value for platelet count, it's 140 to 140 times 10 to the 9th per liter. If you did remember, good for you. Okay, so that's the hallmark. The one in the name, HELLP, would be the hallmark of the disorder. Sometimes I wonder, all disorders should have that kind of name, wherein you just know what's happening based on the name. Okay, so this is a patient who recorded her experience with HELLP, and you can see, okay, the bruises that formed. That's because of the decrease in the platelets. That's how important our platelets are. Because remember, the coagulation factors here are normal. So there's nothing wrong with clotting mechanism if it's only based on coagulation tests. So that's it for MAHA. We jump to macroangiopathic hemolytic anemia. But this is also known as abnormal blood vessel structure. Well, it could affect both large and small blood vessels. Okay, so abnormal blood vessel structure, we have hemangioma, or the Kasabach-Merritt syndrome. This is a tumor in the blood vessels. It could occur in children, okay, and block the blood flow to the area, to any area, causing destruction or death of the tissues. So tissue necrosis. Another would be malignant hypertension. Okay, of course, this is unknown mechanism most of the time, but it could lead to endothelial injury. There would be low platelet count and RBC fragmentation. So there's still thrombocytopenia and schistocytes present. So there could be chronic or mild hemolysis in hemangioma. Hemoglobin is low, of course, and this is intravascular hemolysis. So we have elevated indirect bilirubin, lactate dehydrogenase, and low haptoglobin levels. Next, we have mechanical injury to erythrocytes. Remember, this is extrinsic defect, so something outside of the blood vessels. We have mechanical injury. First would be stress or March hemoglobinuria. Also, now it's known as exercise-induced hemoglobinuria because it's found in patients who had strenuous or high-impact exercise. The reason why it's known as stress or March hemoglobinuria was because it was first found in prisoners of war that were made to walk from point A to point B, okay? And they were walking all throughout the day, and the impact of the feet on the ground would lead to fragmentation of the red blood cells. Okay, so exercise-induced hemoglobinuria, and hemoglobinuria, there's hemoglobin in the urine. So the RBCs are being lysed or damaged within the blood vessels, leading to hemoglobinuria right after exercise. There are no schistocytes present because probably the RBCs are really lysed, okay, and it could not heal itself anymore. This is rare, and it's what forms of exercise would usually lead to hemoglobinuria? If you're asking that, we have long distance running, like marathon. I've even read tennis, intensive cycling, swimming. Sometimes I think, is swimming a high impact sport? Well, maybe the impact against water? I don't know. Maybe if you do a butterfly, because if it's just freestyle, it's like you're gliding along. Okay. Stress or March hemoglobinuria. Dark urine. There's reticulocytosis, and most of the time this would not lead to anemia. Okay, so anemia is rare. We have the Waring-Blender syndrome. Well, because there's heart valve abnormality. The heart valves opens and closes, right? And if there is a heart valve abnormality, then the blood flow within the heart, they say, looks like a blender. That's why it's Waring-Blender syndrome. Okay, there's a whirlpool inside, and that could lead to fragmentation of red blood cells, forming the schistocytes. This is also known as traumatic cardiac hemolytic anemia. So there would be turbulent blood flow because of this implanted heart valves. Okay, so this would be for patients who had their heart valves replaced. And then, of course, we have other mechanisms of injury. This is still extrinsic. Yeah, because the microorganism invaded the RBCs or would produce toxins that could lead to RBC damage. And of course, we start off with our protozoans. Probably know what the next one is, Plasmodium, okay, which would lead to malaria. And we have how many types of malaria? Yes. How many types of Plasmodium do we have? Are you done with your parasitology? Okay. Okay, so can you see this ring form right here? Is that Plasmodium falciparum? Okay, so we have Plasmodium, whether it's falciparum, vivax. What else do we have? The new one is Knowlesi, right? Knowlesi. And why did I forget the other two? I'm not. Ovale and malariae. Okay, so those 5: Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, Plasmodium malariae, and the recent one, Plasmodium knowlesi. Okay, you won't go into the quartan and all of those. And here we have several pictures. Remember, the Plasmodium would invade the red blood cells, and when it is released from the RBC, then it ruptures the RBC, and that causes the hemolysis. Was that the release of the merozoites? Okay, I can't remember. Or I just don't want to remember, probably. It's like when you're asked after a hema exam, oh, what's the answer for this question? And you don't want to think about it. Okay, that feeling. Next, we have Babesia, which is also a protozoan. And it also invades the red blood cells, just like here. I think this is the one with the Maltese cross. Just say yes. And it's also the release of the parasite from the red blood cells that causes the hemolysis. And there's no extra erythrocytic cycle, so it's all in the red blood cells for Babesia. Babesia microti as the most common. Okay, so we have protozoans, and of course we have bacterial infections that could lead to injury. We have Bartonella bacilliformis. Okay. So this is the one that is transmitted through sandfly, or also known as the carrion disease. This is an intracellular cocobacilli. Okay. And it could lead to hemolytic anemia because of a protein that it releases. We also have Clostridium perfringens. Okay. And this is bacilli again, gram-positive bacilli. So this is due to the toxin released by Clostridium perfringens. And there is intravascular hemolysis associated with Clostridium perfringens. Oh, that's all for the infections. Other mechanisms of injury would include taking of drugs like dapsone for leprosy, naphthalene, which is present in mothballs, and exposure to venoms or being bitten by insects or snakes. Yan, snakes, bees, wasps, or spider venom would lead to hemolysis. And then we also have thermal injury for burn patients, those with extensive burns. Because remember, RBCs would lyse when it is heated to 49 degrees Celsius. And there would be acute hemolytic anemia. Okay, so the presence of, can you see this? The schistocytes, just like in hereditary pyropoikilocytosis, we have schistocytes, spherocytes. What else do we have there? Well, that's it. Spherocytes and microspherocytes. This would be evident immediately, but anemia would be observed within 24 to 48 hours after extensive thermal burns. The good thing about this is that it rarely leads to long-term anemia because the bone marrow can compensate, and then the spleen will just remove the poikilocytes present. Okay, so we're done with acquired non-immune hemolytic anemia. Oh, sorry about that. We have one more. Hemodialysis patients who have overheated dialysates. Okay, so if the dialysate is too hot, it could also lead to thermal injury. Okay, so that's the extrinsic part. Now we go to intrinsic part. There's only one. That's the good thing about this. We have PNH, paroxysmal nocturnal hemoglobinuria. And from the name, remember, there is hemolysis, paroxysms in short bursts at night, happening at night, and therefore when the patient wakes up in the morning, then they would have dark urine. Okay, so this is from, let's say, earliest AM to PM. And the cycle continues on. Why? Okay, so here, and that's because of the deficiency of the GPI linkage. Okay, so GPI linkage deficiency. Now, what is a glycosyl phosphatidyl inositol? What is it and what does it do? I think this is a better picture right here. You can see the lipid bilayer, the transmembrane protein, and then we have here our GPI. Okay, glycosyl phosphatidyl inositol. It's in the pathophysiology. So the gene that codes for this protein is found in the X chromosome. The phosphatidylglycan class A gene, or PIGA gene. And this is supposed to anchor two molecules to the surface of the blood cells. We have CD55, or decay accelerating factor, and CD59, which is membrane inhibitor of reactive lysis. Now, what's the purpose of these two molecules right here? Is that it prevents the spontaneous activation of complement. Unfortunately, at night, the pH of the body goes down, so it becomes more acidic, and this would lead to spontaneous activation of complement. If complement is activated, it could lead to cell lysis. So the CD55 and CD59 is there to stop complement activation. Even if it is started, it will not continue to the end stage that would result in cell lysis. So what if this is not present? Okay, if this is not present, then the RBC is susceptible to lysis. Okay, and it will lyse at night. Is it only the RBCs that are affected here? No. Red blood cells, white blood cells, and platelets are all affected in paroxysmal nocturnal hemoglobinuria. The problem is that in white blood cells, if it's lysed, would you see any evidence of it? No, because there's nothing inside it. Of course, there would later on be increased susceptibility to infections, but at that point, there's no evidence of it. If the platelets lyse, will there be immediate bruising? No. Okay, so the immediate sign would be due to red cell lysis. This would lead to chronic intravascular hemolysis, and it's actually the cells from the bone marrow that would cells starting from the bone marrow that would be affected. In some classifications, this is already considered under myeloproliferative disorders because it there's also, what do you call this, involvement of the bone marrow cells. Now, since this is a genetic mutation, then there are three types of PNH according to its level of CD55 and 59. PNH type 1 would have normal levels of CD55 and 59. There is a mutation, but it does not translate to low levels of CD55 and 59. Therefore, there is normal reaction to complement, no problem. PNH type 2 would be relatively resistant to complement. So there's 3 to 5 times more sensitive to complement. There's slight hemolysis. PNH type 3 is the most severe, wherein it's 15 to 25 times more sensitive to complement. PNH type 3 is the most severe form of PNH. Here, this is what happens when there is complement activation, especially for the new batch. Okay, you have here the infected cell. So let's say the RBC is not infected, and the antibodies will bind. Well, when it comes to PNH, there's no need for antibodies. Okay, it's just activated in an alternative manner. So what I'm trying to show you here is the cell lysis. Okay, so it would lead to cell lysis or destruction. There would be small holes, those red areas right there, and water would come in and the cell would burst. So clinical manifestations would include extravascular hemolysis at night and hemoglobinuria upon rising. There would be no major change after. Oh wait, why is that extravascular? That should be intravascular hemolysis at night and hemoglobinuria upon rising. Okay, so intravascular hemolysis. There's no major change after exercise, so nothing, not just like the stress hemoglobinuria or exercise induced. There's weakness, slight jaundice, abdominal pain, and splenomegaly. And there is a complication. Thrombosis could be present in patients with PNH. Okay, so thrombosis is a formation of the blood platelet clump, and this could be fatal. One of the organs that's severely affected by thrombosis in PNH is the liver, particularly the hepatic vein. So if there's a buildup, so none of the blood can go out of the blood of the liver. Okay. Have you heard of Budd-Chiari syndrome? I'm not sure if I'm saying it right. Okay, I cannot find my pen. Okay, Budd-Chiari syndrome, BUDD dash CHIARI. Budd-Chiari. So I'm pronouncing it the way oh, here it is. Oh, it's hard. Okay. That's it. Budd-Chiari syndrome. Thrombosis, and then later on, if this is not resolved, then it could also lead to bone marrow failure, leading to aplastic anemia and myelodysplastic syndrome. Here is a blood picture of a patient with PNH. You can see the reticulocytes if it's stained with a supravital stain. And you can see here the aplasia. It can lead to aplastic anemia. The one on your left, the one on the right is normal. So the patient would have still thrombocytopenia, leukopenia. So as you can see, all the blood cells are affected. So we have here pancytopenia, thrombocytopenia, leukopenia, anemia, but there's reticulocytosis. Okay. Now we have here special laboratory tests. There's only 2, and then we're done finally. And this is totoo na. We have sugar water screening test. This tests for the ability of RBCs to remain intact after complement attachment. What's a general procedure? We have 4.5 ml of 9 to 10% sucrose solution added to 0.5 ml of whole blood, patient's whole blood, and 0.5 ml of control. The control here would be normal patients without PNH. Incubated at 37 degrees Celsius for 30 minutes, and then observe for centrifuge and observe for hemolysis. However, this is not specific. False negative results could be due to no complement in the patient's whole blood, unbuffered sucrose solution, and recent massive transfusion because the RBCs then would be normal. False positives could be due to traumatic venipuncture, so you began with lysed red blood cells, severely anemic specimen, even if the red cells would lyse, then it would not be as evident, and patients with immune hemolytic anemia. So hemolysis could also be present. Sugar water screening test, and then Ham's acidified serum test is another. If you'd remember in CDA type 2, congenital dyserythropoietic anemia, HAMPAS, hereditary erythroblast multinuclearity with a positive acidified serum test. So this is that test, Ham's acidified serum test. So this tests the ability of patients, red cells in patients' defibrinated whole blood to resist complement-mediated lysis in acidified serum. We have a setup of 7 tubes, and you have the table there in your module. And what are the reagents, or what should be prepared? We have fresh normal serum, patient's fresh serum, inactivated serum. What do we mean by inactivated serum? Yes, the complement was removed. So this is serum without any complement. And we have patient's RBCs, we have the control RBC, which are normal RBC, and HCl, 0.2 normal HCl. Let me remind you, in PNH, again, what happens to the RBCs? Why would it lyse? There would be complement activation when there is reduced pH. So low pH causes spontaneous activation of complement, and that could lead to hemolysis because the patient's cells, RBC, WBC, and platelets do not have any GPI linkage. So the GPI linkage is to help attach CD55 and CD59 to the blood cell. Okay, so remember that in tube 1 we have fresh normal serum and patient's RBC. What does that mean? If a patient has PNH, do you think there would be hemolysis here? No. Okay? No. Why? Because there's complement. Remember, we have three things that should be present. Complement, the patient's RBC, and acidic environment. Yes, we have complement that's present in the fresh normal serum. The patient's RBC is there, but there is no acidic environment, so no hemolysis. Okay. Second tube, we have fresh normal serum, patient's RBC, and HCl. Do you think there would be hemolysis? Oh, yes. Okay, so we have the complement, the patient's RBCs, and the acidic environment right here. Okay, so in PNH, tube number 2 will show hemolysis, and you would see that there's +3 hemolysis. Tube 3, patient's fresh serum, patient's RBC, and HCl. Okay, is complement present? Yes, that's provided by the serum. Is the patient's RBC present? Yes, right here. And is there an acidic environment? Yes, again. Okay, so there would be hemolysis. Tube number 4. Tube number 4 contains inactivated serum, patient's RBC, and HCl. Would there be hemolysis? Well, let's go through the checklist. Is there complement? Is there complement? No, because inactivated serum does not have complement. Therefore, even if the rest are present, there would be no hemolysis if the patient has PNH. Okay, are you getting it now? So, tube number 5. Most of these are controls now. Tube number 5, fresh normal serum and control RBC. Okay, so we have normal serum and normal RBC with the normal GPI linkage, so therefore there would be no hemolysis. If tube number 5 shows hemolysis, the test is considered invalid. So it's a control for the normal serum and the control RBC. Tube 6 contains fresh normal serum, control RBC, and HCl. Would there be hemolysis there? No, because the control RBC is normal. Therefore, it has its own protection. Just think of CD55 and CD59 as armors. Okay, so it protects the cells from destruction by the complement. And since normal RBCs would have that armor, it will not lyse. And tube number 7, we have inactivated serum, control RBC, and HCl. Even if we have the acidic environment, we do not have complement, okay, nor the GPI deficient RBC. Therefore, there would be no hemolysis here. If there is hemolysis in tubes 5, 6, and 7, then the test is considered invalid. Yes. Okay. So other conditions that could also have hemolysis or lysis patterns in Ham's test or Ham's acidified serum test would be hereditary spherocytosis. What's the main difference? There would be still hemolysis no matter what type of serum is present. Okay, because this would be incubated. For Ham's acidified serum test, there's incubation, and that would lead to lysis of the RBCs. So as long as the patient's RBC is present with the acidic environment, okay, hypotonic solution, then it would lead to hemolysis in hereditary spherocytosis. How about HEMPAS or CDA type 2? This would only show hemolysis when there is fresh normal serum, patient's RBCs, and the acidic environment. Okay, so those are the hemolytic patterns. This used to be the confirmatory test for PNH, but right now, okay, we go straight to the deficiency, and that would be flow cytometry. So in flow cytometry, it's used to identify whether the cell has CD55 or CD59, okay? And this uses antibodies against CD55 and CD59, and these antibodies would also have labels, okay? Fluorochrome, or something that would help in the sorting of the cells. So those that are positive, let's say for CD55 only, are here, right here, and those with CD59 would go here. Okay, sometimes if they have both, then they go either way. If they don't have it, then they just go straight to something else, and that will show in the result. Okay, so flow cytometry is currently the confirmatory test for PNH. We'll discuss more of this when we reach leukemia. And that's it. Okay, so hopefully you were able to understand that part. It's not very difficult. We have acquired, again, non-immune anemia of increased destruction. It's physical or mechanical injury. We have the microangiopathic hemolytic anemia, wherein it's characterized by schistocytes and thrombocytopenia, DIC, TTP, HUS, and HELP, HELLP would be under that. And then we have other factors, okay, mechanical injury, even infection. And then for intrinsic defect that would cause acquired non-immune hemolytic anemia, we have PNH. So the intrinsic is part of the RBC. The defect is part of the RBC, and that's the loss of the GPI linkage. Okay, so I hope you enjoyed. This is one of the pictures that I took from one of the blood smears this semester. And we'll have more of acquired hemolytic anemia in the next video.